Howdy, everyone. I'm Ian with the marketing team here at Merrick Health. Super excited today. We have Dr. Stephen Campbell. He's our medical director. And for many of you, he may actually be your Merrick Health provider as well. He's going to be talking and presenting to us about thyroid, specifically thyroid antibodies, which is a very uh, interesting and niche rabbit hole and very hard to find really good, cutting edge, accurate information out there. So if you guys have any questions while he's presenting, drop them in the chat. There will be a live Q&A if we have time at the end. As a disclaimer, when it comes to questions, we can't provide medical advice via a webinar. So if you guys do have questions, try to keep them more in the general mechanistic big picture side of things. And then to the audience that's watching on YouTube, if you guys have questions, go to merrickhealth.com, reach out, talk to one of our health coaches, and they'll get you started in the right direction. But without further ado, Dr. Campbell.
All right, thanks Ian. Hope everyone out there is having an awesome Tuesday. I'm going to go ahead and share my screen and we will get rocking and rolling here. Okay, get that out of my way. Start slideshow. Ian, is that okay on your end? Can you see that okay?
Oh, looks good to me. Yeah.
Fantastic. All right. So the way I've structured this talk is we're going to kind of go into some basics first to give you guys some background, and then definitely we'll get to those antibodies. Don't worry about that. But if you're not familiar with where the word thyroid comes from Greek, meaning shield-like or shield. So as you can see, it's shaped like an old-fashioned Greek shield. And I'm going to assume some basic knowledge here in terms of a little bit of structural anatomy and some signaling pathways, but don't worry, I try to keep this very sort of, like you could have a conversation with your fifth grader is always my goal. We can understand this. That's me. I'm the medical director for Merrick Health, and I probably work with many of you out there listening, so thank you. So here's our learning objectives here. Again, I'm not going to spend too much time on this because I want to make sure we have time for questions at the end. But basically, we're going to go over the essential physiology behind thyroid, production of thyroid hormone. And then at the end, we're going to get into the autoimmune issues and some things, steps, interventions that we can take to help with that. Okay. So some basic structure and function of the thyroid gland. If we were to take out the thyroid and look at it underneath a microscope, you have follicular cells that line the central lumen, which is called the colloid, okay? And that colloid is filled with a protein called thyroglobulin. That's going to become important in a little bit when we talk about antibodies, right? Because what is one of the main antibodies? Anti-thyroglobulin, okay? Now, these follicular cells are also important to keep in mind because when patients develop thyroid cancer, it's usually from these follicular cells that give rise to that in the most common types of thyroid cancer, like papillary thyroid or follicular thyroid cancer. Now, also of note, the parafollicular cells that are within this gland, they can give rise to a different type of thyroid cancer called medullary thyroid cancer. The reason I bring this up is because for me, I find it helpful to be able to connect many different pathways and disease processes. Helps me keep things straight in my head and remember things. So if you've ever been involved with any of the weight loss drugs, Ozempic, Wegovy, etc., you'll notice they have a black box warning about medullary thyroid cancer, right? The reason being is that in some of the rodent models in early studies, they were seeing increased rates of this medullary thyroid cancer. So if anyone has a personal or strong family history of this type of cancer, it is recommended to not go on these drugs. But again, as you can see, far and away, the more common types of thyroid cancer, it's not an issue. And there's not any human clinical data when they've done some fairly robust meta-analyses thus far with several years of data. It's not really panning out in humans. Regardless, the black box warning is still there. So just a little tidbit of knowledge for you all as we get rolling here. A little bit more about the structure and function. I mentioned thyroglobulin in that central lumen. So this is a protein. It's that red streak that you can see going around here. That's kind of the representation of this big protein molecule. Now, when we ingest dietary iodide, the first thing we have to do is convert it and oxidize it to iodine, okay? Then what we're going to do is we're going to have these amino acids attached to this thyroglobulin protein. Amino acid is called tyrosine. Now, when we use this thyroid peroxidase enzyme, okay, does that sound familiar? That's the other main antibody in Hashimoto's, anti-thyroid peroxidase, abbreviated anti-TPO. This is how it comes into play right here. So it's tacking on iodine molecules to the tyrosine amino acid. you're still on this thyroglobulin lattice work. Okay, think of it as like a scaffolding to build thyroid hormone on. Then what happens next is you take two of these tyrosine molecules that are iodinated, stick them together, and there's your thyroid hormone, also called thyroxine, right? It's just two tyrosines with several iodines attached to it, and that's your thyroid hormone. So you can kind of see some more structures over there. To the left, your thyroid gland is primarily going to make T4, okay? T4 just means there's 4 iodines. Now, really the main player here, though, is going to be T3. So you have to convert T4 to T3 in the periphery to really get a lot of your action there, okay? The affinity of T4 for the nuclear receptor is fairly poor in relation to T3. So T4 is more or less like a pro-hormone for T3. What's interesting is that most standard labs, most practices are not even going to measure free T3. You're going to get your TSH. Occasionally you'll get a free T4 in there, but most of the time, most of the professional societies do not recommend checking for T3, even though, again, it's the primary player. There's a lot of reasons for that we can maybe get into later, but save that. So again, when you have the pro-hormone T4, you have to take an iodine off of it to get your active T3. Where you take that iodine off is important in which enzyme you use. So you have deiodinase enzymes that can convert T4 to active T3, or you can go down an alternative pathway to make reverse T3, which is inactive. You can also measure reverse T3 levels in serum too. Again, not commonly done, but it can sometimes give you a more comprehensive picture of thyroid function. And just remember again, to emphasize, T4 is a pro-hormone for T3. T3 has a very short half-life. This is why you don't see people out there being treated for thyroid hypothyroidism with just T3, because half-life is only 6 to 8 hours. And so T4 is a much more prolonged half-life of 6 to 8 days, okay? Now, just like a lot of other hormones in the body, thyroid hormone is primarily bound to proteins. You have different types of these proteins that I showed over there on the top left of your screen. Not very important to know those types of proteins, just more for reference. Now, measurement of thyroid hormone. How do we do it? Most of the time, any standard lab is going to measure immunoassays, okay? So it's binding antigens and antibodies, which are all just proteins that are binding together to measure that. Now, there are ways to get more precise measurements through LCMS, right? Liquid chromatography mass spectrometry. I'm sorry, that's a long, complicated term. LabCorp, for instance, offers this. It's more expensive, not commonly done. By and large, the vast majority of time we're measuring thyroid hormone, it's going to be through an immunoassay, okay? Why is that important? Biotin, right? So a lot of people out there are taking biotin supplements now. Hair, skin, and nails, everyone wants better improvement in that arena, okay? So if you think about how much biotin you get in your diet, and you look at how much is actually in these supplements, you're getting hundreds of times more than you would otherwise get in your diet. So 10 to 30 milligrams of biotin in a lot of these supplements. The reason it comes into play with an immunoassay is because the immunoassays use the streptozide biotin complex. And so if you're taking a lot of biotin, it's going to interfere with that. And it interferes with it in a very particular manner. It's going to suppress the TSH, and it's going to elevate levels of both free T3 and free T4. So if you had someone, let's picture a scenario where somebody is taking levothyroxine for their hypothyroidism. They go in their doctor, get their labs done. Hey, everything looks great. You know, your TSH is 1, right? And your free T4 level looks good. Usually they don't check a free T3. However, if that patient was taking biotin, it could falsely be showing them good control. Whereas if they were not taking biotin, maybe their TSH is more like 5, okay? So these things happen quite often. That's why you'll see on the lab reports, sometimes it'll say mega doses of biotin can interfere with this assay, right? So it's important to know that because these supplements are very common out there. And so the usual sort of byline is to avoid anything with biotin in it for 72 hours. Now, multivitamins are not oftentimes going to be the culprit, because if there is a biotin component to a multivitamin, it's usually going to be in a fairly small amount. I'd worry more about these specific hair, skin, and nail type supplements with a lot higher dosages. So again, just be aware of that. A lot of people don't know this or understand it about why biotin is important when we're measuring thyroid hormones. It's not just with thyroid, by the way, it's with other things, but for this talk, I'm just sticking with thyroid.
Critical importance if you want to understand what's going on with your body. whether that be preventing disease, optimizing performance. Getting blood work done is incredibly important on at least a biannual basis, in my opinion, is what I do personally. Understandably so, knowing what to order and how to interpret it is beyond overwhelming. It's incredibly nuanced to interpret blood work with the level of rigor that is needed to actually assess the root cause of many underlying issues and or hit the perfect balance of optimization. And that's where Merrick Health comes in, with highly educated coaches and medical providers who are always staying on the cutting edge, always on top of the most recent literature to give the most rigorous interpretation of your current health status, interpret if there's any ways to optimize your lifestyle, supplementation, sleep hygiene, diet, pharmacology. It's all taken into account here at Merrick Health. So if you want to take control of your health and or optimize your performance, check us out, merrickhealth.com.
So again, what are common scenarios people go to the doctor for, right? Fatigue, inability to lose weight, brain fog. And they always want to know, or one of the things they want to know is the thyroid a culprit here, right? And usually it's that TSH reflex test that gets ordered on almost everyone. The TSH is normal range. No further labs get done, usually not. Now, some people will order a free T4, but almost never do I see a free T3 out in common practice, and never do I see reverse T3. So again, that's usually the end of the story right there, is once the TSH is normal. So the next question they might ask is, okay, my TSH is normal, but how can I get optimal thyroid function? We have lots of data showing us that TSHs within a more tight range lead to a lot of improvements in health outcomes and symptoms. But usually you're not going to get a very satisfactory answer as long as that TSH falls within that standard lab reference range, right? Which can be frustrating for a lot of people. So the current big pharma approach is normalizing TSH with levothyroxine. Remember, we already talked about the structure of thyroxine, what that is. The levo that's added in front of that word is because the particular molecule has different isomers. It's also levo and dexo. Kind of think of it as handedness, left and right-handed, right? So if you took a mirror reflection of levothyroxine, its mirror reflection would be dexothyroxine, and they would not be superimposable on one another. And so anyway, naturally our bodies make levothyroxine, and that's what we usually synthesize. So that's where that comes from, just to give you some background on that, because a lot of people don't realize that. Okay. Very common problem to have hypothyroidism. It's a big moneymaker. About 5% of the population. It's probably one of the top 3 to 4 drugs prescribed worldwide. Talk to any pharmacist, they are filling Synthroid all day, every day. Okay. So what about other impacts of thyroid function, right? We know that thyroid is going to play a role in, you can name your organ system, it's going to be affected in some way by thyroid, and vice versa. Okay. Sorry, it's not advancing for me here. My slide, there we go. Okay, sorry about that. So again, why would we want to optimize thyroid function? And I'm not just talking about normalization of TSH, looking a little bit beyond that. I've got a lot of references down here because there's a ton of published data around this in terms of looking at, what are the best optimal ranges for TSH and free T3 and T4 levels, right? So we know that even deviations of a little bit off optimal ranges are associations with increased cardiac events. Even low T3, which I remember I told you is hardly ever measured, is an independent risk factor for mortality related to endothelial function and dyslipidemia. T3 in of itself is actually a positive inotrope on the heart, meaning that it improves contractility of the heart. So all those things are very important, and also sexual health. A lot of people don't realize that too, that it has its roles there. Okay. So again, even slightly elevated TSH levels are associated with increased rates of obesity. So we're not talking about that, 0.7 to 4.5 range. We're talking about a little bit tighter range there. You can see higher TSHs with cognitive difficulties. We know that thyroid hormone is very important in beta oxidation of fat. It's going to reduce that visceral adipose tissue. Those of you that had your in-body scan or DEXA scan and are worried about visceral fat, this is another good way to improve that, making sure that levels are well controlled. Subclinical hypothyroidism, right? So your TSH is elevated, but not to the degree of qualifying you for overt hypothyroidism, or maybe you don't have predominant symptoms yet with a TSH that's slightly elevated. So even subclinical hypothyroidism has a lot of negative associations with it, right? Impaired fatty acid oxidation, higher risk of developing metabolic associated fatty liver disease, more increases in visceral adipose tissue. Now, if you look at a lot of the recommendations from professional societies, there's a very big fear about using thyroid hormone in patients over 70 due to risk of thyroid toxicosis. Again, what you'll find is that there's this concern about cardiac and skeletal issues from being too aggressive with thyroid hormone. Now, I certainly think that there's a Goldilocks zone, just like with everything in biology, but I think the risk of using exogenous thyroid hormones in causing those types of issues like atrial fibrillation and osteoporosis are really overstated and oftentimes extrapolated from pathologic entities like Graves' disease, which is an autoimmune process that we'll get into later. Anyway, that's kind of been my interpretation of some of the literature that's out there. So before we move on, just to give you some idea of extremes of thyroid dysfunction that are rare but still happen out there, right? So the extreme case of poor low thyroid function or hypothyroidism is myxedema coma. So you actually can get these changes in your subcutaneous tissue called myxedema. They get very swollen. You get almost, in the most severe cases, you become essentially comatose and unresponsive. I've seen that come into the hospital a handful of times, and you need actually IV thyroid replacement in order to address that. Sometimes you need mechanical ventilation due to the profound degree of coma that can happen. So it's an extreme case, right? But it helps illustrate some of the symptoms that we look out for that suggest low thyroid function. The other end of that, very high hyperthyroid, right? Thyroid toxicosis is the clinical manifestation of hyperthyroidism. You can have elevated levels of T3 and T4, but not have any clinical evidence of thyroid toxicosis. It's a pretty serious condition, okay, where you'll have, a lot of anxiety, palpitations, tremors, those types of things, and you can get pretty life-threatening arrhythmias in the most severe cases. But again, usually what you're seeing this in, the most common cause of thyroid toxicosis is Graves' disease, which is an autoimmune disease. This is not people taking too much Synthroid. This is an autoimmune process with thyroid-stimulating antibodies that are causing a lot of this. The exophthalmos that you'll see there, you've probably seen people out there where the eyes are bulging. That's actually an effect, even though it's debatable, an effect from the antibodies in Graves' disease that cause periorbital edema in the soft tissue behind there, okay? Again, you're not going to get exophthalmos taking too much thyroid hormone. So it's a common fear and misconception out there. Okay. So just to summarize a couple things there, we know optimal functioning thyroid is good for cardiovascular health, body composition, less visceral adipose tissue, cognition, sexual health. And before we go into those antibodies I know you're all looking forward to, let's talk a little bit about the pillars of health and its impact on thyroid function, because it also plays a role in autoimmunity too. So sleep, right? We know that poor sleep is going to adversely affect our thyroid axis, right? We know that it can cause actual hypothyroidism when sleep is poor. The other side of that is that when the thyroid is not working properly, it actually increases your risk of obstructive sleep apnea, restless leg syndrome. So these two things kind of feed each other, right? Bidirectional relationship, okay? So what's some ways to assess sleep? I think all of us are pretty familiar with general sleep hygiene practices. It's really not so much about throwing a bunch of things at the wall and seeing what sticks. It's more getting some data behind it and seeing what changes make sense, right? What interventions. I think that the preponderance out there of various devices to get data around this is good. Oura rings, Whoop straps, you name it. Home sleep studies to evaluate for periods of apnea, right? Apnea or hypopnea is always valuable in a lot of people that don't realize they have problems with their sleep. Looking at melatonin levels is another potential avenue, right? Because melatonin levels tend to decline with age, so they may indirectly cause some HPT axis dysfunction, right? Melatonin is also a very important antioxidant. And if that thyroid gland has an imbalance of oxidative stress, that can certainly affect things adversely. So many obvious roles there. Stress. So cortisol is a known inhibitor of peripheral T4 to T3 conversion, right? You also see this in acute illness. We get more reverse T3. We see this all the time if we measure thyroid hormones when somebody's in the hospital, which we don't recommend because they're usually going to be thrown off due to that illness. Starvation, low caloric diets will also adversely impact thyroid function. And these are all things that can be measured, right? You can check cortisol levels, salivary cortisol levels throughout the day and kind of see what's going on there, see if that's a factor. Looking at potential roles of stress management, different adaptogens, phosphatidylserine, which modulates cortisol release from the adrenal glands. How are you winding down? Does that make sense for your life? And then in women, right? So women that have issues with PCOS, perimenopausal, right? We know that progesterone levels are actually very important. They can actually raise free thyroid hormone levels. So again, there's many different things to look at, many different angles to consider when trying to optimize thyroid function. In terms of exercise, so spending more time in a maximal fat oxidation state is going to be very beneficial for many things, including, improving visceral fat levels, increasing HDL, lowering blood pressure, VO2 max, right? We talk about VO2 max a lot, which is our maximal aerobic capacity, kind of a measurement of our fitness that has many, many important key associations to our longevity and health. The better your VO2 max is in a linear relationship, the better your long-term outcomes are, right? So again, there are ways to really sort of dial this in better. I think that if you tell people, do more zone 2, a lot of people aren't going to know how the hell to do that. Excuse my language. But I think that if you give them targets and there's ways to assess this, saying, okay, for you, we've done a cardiopulmonary exercise test, we've done some surrogate of that, and we know that what your fat burning zone is and your specific target heart rates. You can estimate these, right? The Maffetone approach, Maffetone number, Phil Maffetone studied this for many years, or you can actually measure it directly. I'm kind of a data guy, so I prefer measuring it and giving people targets. So this individual that I put an example of, their fat burning zone is really around 93 to 107 beats per minute. And that the maximal bang for your buck is going to be right at about 107. If they get above 139, they're really not going to be burning fat at that point. That's kind of redlining it and should kind of keep that type of training to a minimum in terms of their goals of improving thyroid function. So again, many different levers you can pull. Now, nutrition is kind of a big rabbit hole that I'm going to take you part of the way down. Because I think there's a lot of, again, misconceptions, incomplete understanding of some of these things. So you can see in this picture here, all the different minerals and cofactors that are involved in producing adequate amounts of T3, right? Remember, T3 is the ultimate, most important product of thyroid hormone synthesis. Iron, selenium, zinc, iodine, all critical. Additionally, amino acid stores, right? Methylation status, also important. We get a lot of our substrate for thyroid hormone. Remember I told you that it was tyrosine, right? How we had tyrosine attached to thyroglobulin proteins, and we're taking that tyrosine, we're putting iodines on tyrosine, we're melting it together to make thyroxine, and then we're deiodinating it to make T3. All those things require different cofactors, okay? One of the ways we get tyrosine is we actually convert phenylalanine to tyrosine, okay? And that's going to, again, the theme of the day, it's going to require many different cofactors for that, okay? Oxidative stress is always a bad thing. It's always going to negatively impact thyroid function, raise levels of reverse T3, okay? So methylation, again, we're not going to go into super great detail here. What I want you to know is that methylation is critical in converting phenylalanine to tyrosine. 40% of the population estimates have some defect in methylation, meaning that they're not going to do this process. They're not going to run these different turbines and these cycles as efficiently as they otherwise could. And so they might need some support through methylated B vitamins, particularly folate and B12. So, homocysteine level is a common marker that we use to sort of get a surrogate for this. There are more precise ways to do that, but for the most part, that's a general good starting point to see if that's potentially an issue. Iodine's a big one. A lot of people don't realize that they're deficient in iodine, especially since most people these days aren't using table salt anymore. There's minimum requirements. Primary sources tend to be, seafood and different types of products such as that. Low iodine is still a big deal worldwide. A lot of goiters in underdeveloped countries related to iodine deficiencies. Many different supplements out there will have some degree of about 100 to 400 micrograms of iodine. Now you can measure iodine levels, right? But usually it's not ideal to measure it in the serum, in the blood. You'd actually prefer measuring it in the urine. It actually gives you a more accurate assessment. 24-hour is best. Barring that, a first morning void measuring can be a decent way to check it, okay? Now, what's interesting about iodine, like with a lot of things in biology, the Goldilocks effect, right? Too much is bad, just as too little is bad. If you take too much iodine in, you can actually suppress the enzymes involved in thyroid hormone production. Okay, you can suppress that. Your body's not going to want to absorb as much iodine through that Duox enzyme. Remember, I showed you that in the very beginning. That's how we change our dietary iodide into iodine. If you're taking too much iodide in, the body's going to shut down that enzyme, among other enzymes too. So not a good thing if you think that you're taking a bunch of iodine and doing yourself any favors, because it can actually be detrimental. Where do I see this all the time? For some reason, people think Lugol's is a good thing to take. I would tell you that except for very rare circumstances, I would avoid Lugol's. Okay, it's a ton of iodine, right? Earlier I was talking about micrograms, hundreds of micrograms. A 5% Lugol solution, just one drop, has 6.25 milligrams. Okay, that's a ton. Very easy to overdose with this. And again, the indications for that, if you're really trying to suppress thyroid function for whatever reason, right? If a nuclear bomb goes off, knock on plastic that I'm around, it would be a reasonable thing to take it due to the radioactive isotope exposure. You wouldn't want that stuff to go to the thyroid gland, because the thyroid gland is very prone to developing cancer. But barring that, I really don't see much reason to use this stuff. So avoid it unless you have very specific reasons for taking Lugol's. Okay, just too much iodine. Other trace minerals that oftentimes get brought up. So fluoride, just like it can impact absorption of a lot of things, can impact iodine absorption, right? It's in a lot of drinking water supplies. I think that's been spoken about quite often. Bromide, very similar in plastics and commercial dough preparations, okay, flour preparations. I've also heard chloride brought up, but I haven't found any literature to support that. There's more issues of chloride in terms of asthma and respiratory diseases, but nothing I've found that really is convincing about thyroid. But just to be aware of some of these environmental exposures. Iron's a big one, right? So we know that iron is important in our red blood cells and binding oxygen, transporting oxygen in hemoglobin, but it also helps in the synthesis of thyroid peroxidase enzyme, okay? Remember that enzyme I showed you in the very beginning, right? We had thyroglobulin protein and thyroid peroxidase enzyme helping along all those steps of synthesizing thyroid hormone, okay? So iron is involved in that, right? So if you don't have adequate iron, we're not gonna be able to run that TPO enzyme as well as we should, okay? Now, the difference between animal-based and plant-based sources of iron are significant. Animal-based sources of iron are going to be heme iron, different absorption pathway through the gut, 25 to 30% versus 1 to 10% absorption in vegetable-based sources, okay? And if you're gonna take an iron supplement, please don't take iron sulfate. I still see this. This is the most commonly prescribed iron supplement. It's old school, right? We used to give this out in the hospital. It causes a lot of stomach upset, constipation. People hate it. The newer forms of iron out there that are bound to like amino acids, like an iron bisglycinate, far, far superior, far better absorbed, and not very expensive. So just keep that in mind if your iron levels are low, different strategies you can do there, okay? So again, this is just kind of talking about different absorption pathways of iron. This isn't an iron talk, so I'm not going to go into that too much. Some things to keep in mind, a lot of people out there that are on acid blocking medications, stomach acid is actually very important to reduce the iron to make it absorb better. So without stomach acid, you're going to have a hard time with that. Vitamin C and its acidic properties are going to help absorb iron. So some supplements out there will already have vitamin C in it, okay? Again, Goldilocks effect we keep talking about. Too much iron is a bad thing. There's something called the Fenton reaction, generates free radicals. You can also think of this as a rusting reaction. So whenever we're looking at iron levels, we want to make sure that we're not dealing with either a deficiency or an overload state, okay? So you want to optimize levels, but without going overboard. Selenium is a huge one, right? We know that selenium is critical for appropriate thyroid function. It's a very powerful antioxidant. As you move through those steps, remember I mentioned oxidative stress as being a key player in making T3. Now, you can theoretically get some selenium excess. I've never seen that, but that literature is out there in case reports. Now, I guess if you were having multiple cups of Brazil nuts every day, you could get some selenium toxicity, but you'd have to be doing that pretty consistently. And like I said, I have not seen that. So most thyroid supplements, again, will have some degree of selenium in them. Now, if you're having some Brazil nuts every day, you probably don't need it. But yeah, to each his or her own on that. Zinc, right? Another trace mineral. It's very important. Also plays a role in T4 to T3 conversion. Usual recommended intake around 15 milligrams. It's going to be very hard to do that with diet, thus the supplement recommendations. Toxicity is rare. The biggest thing you run into, we saw this during COVID a lot, and people taking mega doses of zinc every day, is that too much zinc, as in this diagram here, will actually interfere with copper absorption through the gut. Okay, and so you can actually get copper deficiency with prolonged zinc excess, which can lead to many different clinical symptoms. So just be aware of that. You can overdo zinc, just like you can overdo selenium, iron, everything else, right? Always a balance. Oxidative stress in general, there's different ways to address that. Certain different monounsaturated fatty acids, and berberine is actually also a good way to reduce oxidative stress in certain cases, particularly if there's insulin resistance. So again, I'm bringing up all these factors because these are things you really need to think about as we're going through someone with suboptimal thyroid function, okay? Now, gut health is a big one. I'm a big gut health person. I'm always looking at this pretty carefully. And it's a really interesting data behind this. And really, you could pick these days almost any organ disease and find many different associations, connections with gut health. But if you compare the microbiome composition, someone with good thyroid function to someone with poor thyroid function, you'll actually see different populations of certain bacteria. Dysbiosis is a known source of chronic inflammation and autoimmunity, which can definitely alter thyroid hormone balance. Certain probiotics regimens have been shown to improve thyroid function, again, if you're increasing those lactobacilli and bifidobacterium species, right? And all those things that I just spent a few minutes talking to you about before, the different minerals, right? Everything from selenium, iodine, zinc, iron, all of those things and the way that you absorb them, metabolize them are affected by your gut microbiome. So it's clearly playing a huge role there. Also, looking at the other direction, thyroid function in of itself is going to have positive impacts or negative impacts depending on gut health. So T3 actually helps to regulate development and differentiation of your intestinal epithelial cells. Okay, so if you have hypothyroidism, you can actually impair your intestinal motility, right? Because thyroid hormone can stimulate those motility factors in the gut, which can lead to an increased risk of developing SIBO, which is small intestinal bacterial overgrowth. Which, if you think about it, if we're not moving things through our small intestine efficiently, those bacteria can sit there and fester and overgrow and cause a lot of problems of bloating, digestion, etc. So then if you develop that SIBO, then you can also get farther worsening of neuromuscular dysfunction, delayed gastric emptying, low stomach acid, all of these things, which are then going to cycle back and they're going to worsen thyroid function. So you can kind of see that spiral that you can get into there with poor gut health. Okay. So looking at gut health and something called about intestinal permeability, right? Also called leaky gut. So why is this important? No, so we're starting to get now into the autoimmune picture, autoimmune piece, right? So if you have intestinal permeability, some have suggested that that is a necessary requirement for development of autoimmune disease. Yes, there is a genetic component. Yes, there is an environmental component. But unless there's some sort of a barrier dysfunction, how else would we develop this process of autoimmunity? The theory being, and that's been shown experimentally too, is that food antigens, as they go through, if we have leaky gut or intestinal permeability, if larger particles, different antigens or protein structures from these foods can then slip through that barrier, there's something called molecular mimicry. So the immune system is going to see these antigens and particles. It's going to make antibodies to them. Those antibodies that can then cross-react with our own tissue, such as the thyroid gland, right? Anti-TPO, anti-TG antibodies, all those things, which can then lead to overt manifestation of thyroid disease, okay, like Hashimoto's. So interesting connection there. And again, I'm not going to stand here and say that, hey, if we fix your gut health, we're going to cure all autoimmune disease. I wouldn't go that far, right? But I think there's an unquestionable link there and importance in addressing this, okay? So we get the scenario where you have some thyroid antibodies. This person right here has some anti-TPO, anti-thyroid peroxidase. They see these antibodies, yeah, my TSH is okay. You're probably going to be told, yeah, these antibodies, they're not really impacting anything. We'll just ignore it. Now, these usually don't get measured on a standard panel, but with our panels, we're measuring these all the time, and we're seeing quite a lot of people come back positive, right? So if you look in general, we all know that autoimmune disease is skyrocketing in terms of its incidences, right? And some people have blamed that on environmental factors, you know, our Western diets, whatever it is, it's on the rise, okay? And again, I show that sort of pictorial representation of the different factors here, right? So genetics, infections, toxins, dietary components, all those things can definitely play a role, okay? And then we know too that women are much more susceptible to autoimmune diseases, not just thyroid, but Sjogren's, lupus, and many others. There's some interesting literature on there about why this is. Why do women get more autoimmune disease? Some have suggested that it's an evolutionary advantage that women have more active, more sort of hyper responsive immune systems because it protects their children, right? As their children are in the womb, we want them to be protected from infection. And so some have suggested that that's the reasoning for a higher tendency towards autoimmunity. I don't know if that's the whole story, but I saw some interesting literature on that. So that's one piece of it, right? Is that the different factors here, more common in women. And also keep in mind that when you have autoantibodies present to the thyroid globulin, thyroid peroxidase antibodies, it's not diagnostic in of itself that you have Hashimoto's disease. However, if you have the antibodies, you're certainly at risk for eventually developing disease if you don't already have it, okay? And so the average time from detection of antibodies to actual clinical symptoms is 7 years. And that's an average. So some people can have antibodies indefinitely and never develop disease. Some people can have the antibodies and develop disease, within the next couple months. It's a wide spectrum of things, okay? So just keep that in mind, that it's certainly a risk factor. So you can see here that years preceding clinical disease in the column here for thyroid detected antibodies, about 7 years, okay? And that includes thyroid globulin, thyroid peroxidase. Now this third antibody here, anti-TSH receptor, not commonly measured. So this one is a player in Graves' disease. So if somebody has hyperthyroidism, which again, like I told you towards the beginning, is far less common. In those cases, it would be reasonable to measure for all 3 antibodies. But for most people that are presenting with symptoms or concerns for hypothyroidism, usually we check the thyroid globulin and thyroid peroxidase antibodies because you can see there the numbers. Over 90% of patients with Hashimoto's will have one or both of these antibodies, okay? So now, let's say that you have the antibodies, but no symptoms. We already talked about 7 years, right? So just to give you an example of that, looking at farther out, they did a 20-year follow-up study. These were women who had biochemical, so they initially had the positive antibodies. Their TSH was still kind of in that subclinical hypothyroidism, but not overt hypothyroidism yet. And at 20 years, 55% of them had developed overt disease, okay? So I don't think you can just look at these antibodies being positive and brush it off and say, yeah, we're good. I think it's a kind of a wake-up call to, if there's not disease yet, saying, hey, the body is clearly attacking its own tissues here. There maybe or may not be some degree of thyroid gland destruction, but we should start thinking about some interventions here to optimize function and sort of cut off the source of autoimmunity, right? So those are all things that I start to think about when I see those. Just to give you a quick overview about Graves', just because again, I think a lot of people don't understand this too much, is that when there are elevations in thyroid hormones in hyperthyroidism, we do measure a different set of antibodies, the TSH receptor antibody. And if that's positive, it's diagnostic for Graves', right? Which is a completely different treatment pathway that I'm not going to go into. This is just more of, in case you're concerned about why aren't you measuring my TSH receptor antibodies, we're not going to measure them unless there's, again, concern for hyperthyroidism, okay? So let's talk about, again, cutting off the source of autoimmunity, particularly looking at the gut and diet. So I mentioned earlier molecular mimicry, right? Which is this phenomenon by which different foods that are broken down in our guts can have antigens that leak through our intestines, through the intestinal cell wall layer, and can then cause generation of antibodies that can cross-react. So what this is showing you here is a high degree of cross-reactivity between wheat antibody and TPO, thyroid peroxidase enzyme, okay? Remember, that's one of the key players in Hashimoto's. So I would say if somebody has thyroid autoantibodies, it might be reasonable to consider elimination diet if they haven't already done one. Kind of giving some clues there with that, right? What about some other foods? So here's some more studies and some more clinical data. Sorry, not clinical data, this is experimental data, showing other things that can cross-react with thyroid peroxidase and T3. And what you can see there is that the positive control is 5+ signs, right? And so the main players here that showed high cross-reactivity were things like lentils, wheat germ, mushrooms, and peas. So if we start to think about, okay, what's the best diet for somebody with thyroid antibodies to be on? Maybe it's also reasonable to eliminate these particular types of foods because we've seen experimental data that suggests some cross-reactivity there, okay? In addition, doing some digestive enzymes may also be beneficial because maybe we need some assistance with breakdown of different foods to help so we don't generate as many antigens. Okay. What about supplements? So I know people say, yeah, I've done all the diet stuff. I've done my autoimmune paleo diet, but my antibody numbers are still high. What more can I do? What other things can I do? Fair enough question. So vitamin D levels are going to be very important. Now, I think that if you look for any direct human clinical trials showing which intervention directly lowers antibodies, you're not going to come up with much. I'll show you some in a little bit, but it's not like we gave intervention X and we made antibodies go down to 0. No, I'm really not seeing anything out there like this. So I think that doing a multimodal approach using what we have good data behind is what I usually advocate for, okay? Approaching it on multiple fronts. Vitamin D is easy, right? Titrating at 50 to 80. We know that the majority of autoimmune diseases are associated with low vitamin D levels. And actually, if you're not aware, the latest clinical guidelines have come out saying to not test for vitamin D anymore just because of lack of good interventional trial data. Now, we're not going to get into the ins and outs of that, but just know that it might come to a point where your insurance company, when you go to your doctor, is no longer going to cover vitamin D testing. So just be aware that's out there. Regardless, I think it's still very important to do. So now there is some trials that did show that they gave vitamin D and the antibody titers have gone down. Okay, vitamin A is also important. We know vitamin A is very crucial in any sort of mucosal immunity, respiratory, GI tract. We know that it can improve those tight junctions. Remember, I talked about intestinal permeability. Vitamin A can be helpful there. And it's kind of synergistic with vitamin D as well. Some direct effects in the gut microbiome, immunomodulatory. Higher dose fish oils, right? EPA, DHA, those are omega-3s. GLA is actually an omega-6, but it's a beneficial omega-6. I don't want you to think that all omega-6s are bad. It's an oversimplification. But this type of regimen does improve thyroid function. There is some theoretical impact on antibody titers, really extrapolated from other autoimmune diseases, though. Higher dose DHEA, now this is a really high dose, 100 to 200 milligrams per day. As long as you can tolerate it, right, you're not getting horrible acne if you take that much DHEA. But there is some reasonable clinical trial data here as well. We know that it's immunomodulatory, suppresses inflammatory cytokines. There was even a small trial where they gave elderly men with autoimmune hypothyroidism a dose of 50, so less than that 100 to 200 mark, but they still saw improved parameters there. So higher dosages of DHEA may be beneficial as well, okay? So this is just to show you, I mentioned earlier the GLA, you can see gamma-linolenic acid right here. Why is it beneficial? Because you can see that when we go to DGLA, dihomogamma-linolenic acid, it can actually give you some of those less inflammatory eicosanoids or signaling molecules there. Now you'd want to take it alongside EPA, right? Because EPA is going to inhibit this delta-5 desaturase step, which would generate arachidonic acid. So we really don't want too much arachidonic acid that's pro-inflammatory. But if we have GLA and DGLA up in here, that can be helpful and synergistic with our EPA and DHA levels. So just to give you an idea of why GLA is important, it's oftentimes ignored. Some blends out there of fish oils will have some degree of omega-6s in them too, okay? All right, so other supplements that are out there, inositol and selenium. We've talked about selenium a lot already. We know it's super important. We know the impacts it can have. There is a small trial. I showed the graphs here just so you can get an idea. These are not making antibodies go to 0. They're having a modest impact on antibody titers. It's still statistically significant, but I don't want you to think that you can go out and take some selenium and inositol. Next time you get labs, your antibodies are going to be 0. It doesn't work like that, okay? So that's why I mentioned towards the beginning of the supplement talk using multiple different approaches, okay? Nigella sativa, also called black cumin seed oil, is another one there. Ashwagandha. I know a lot of people out there like ashwagandha for its properties in helping testosterone levels. It's also helpful here as long as you're someone that can tolerate it. Okay. So several different ideas I'm giving you there. A lot of people want to hang their hat on LDN as kind of the miracle agent, right? Low dose naltrexone. I think that there's a role for it in certain instances, right? Particularly if there's other autoimmune conditions present as well, especially inflammatory bowel disease. I think there's stronger data in that realm. The theory behind using low-dose naltrexone is that due to the fact that it's a short-term blocker or antagonist at the opioid receptor, you can get this rebound effect of increasing your endogenous opioids and these enkephalin endorphin signaling molecules, which can be immunomodulatory and have other positive benefits. You can see there the presumed mechanism of how it reduces inflammation and antibody levels. Again, I've not seen, to my knowledge, any well-done human clinical trial that showed benefit in this particular case, but it does have other data and, like I said, other autoimmune processes. So I reserve it for more refractory cases. Now, if someone really is dead set on going on LDN, I mean, I think in terms of risk benefit, I think your risk of using LDN is so low that I'd probably be comfortable doing that. But just know that it doesn't have the strongest data behind it in terms of autoimmune thyroid disease. Okay. So again, we alluded to this earlier. Autoimmune diets, eliminating those things that I mentioned earlier, especially if someone has never done this before. Usually doing that for a period of a couple months, around then combining it with gut healing protocols. You know, I think that it's worth a pretty full gut assessment if somebody has autoimmune issues. Sometimes that can be harder to work with patients on if there are no gut symptoms. They'll be like, why the heck are we checking my gut health? I don't have any symptoms. But again, due to the strong link with autoimmunity, sometimes I will sort of have that discussion about checking those types of parameters, labs and stool studies and those types of things. Okay. All right. So kind of wrapping up here, and I'll let you guys ask some questions. Make sure we have time. My thyroid function is normal, but what about the antibodies? I really don't feel like my energy, weight, cognition are where they should be. So I think it's at that point in time, someone is saying that it's a really good opportunity to then investigate all the different pillars of health that we went over, all those different micronutrients, antioxidant balance, you know, what is your gut health like? You know, considering dietary intervention trials along with targeted supplementations and other sorts of levers that you can pull, and hormone health, other hormones that are involved, sex hormones, cortisol, DHEA, fish oil. There's so many things that you can do, and then retesting, right? So doing some interventions that make sense. Hopefully you're also doing some interventions that don't just make sense for thyroid, but also play into many other different body systems, right? So that's my initial approach. And again, I'm not going to sit here and claim that I have the cure for autoimmune thyroid disease, but I think that it's a work in progress, and I'm continuing to search the literature, look for other approaches. I don't think LDN is the be all end all solution, like I showed you before, but again, that's kind of been my approach here, and using different supplements and interventions. So I hope that was helpful for you guys. If you learned a few things there, kind of showed you some of the complexities and nuances. But yeah, I will stop my screen share there. And Ian, if there's any questions, I'll be happy to take them.
Yeah, first and foremost, thank you. That was phenomenal and really well articulated. Number of questions just about if a recording is going to be available for people who joined a little bit late. There will be a recording. We'll upload it to YouTube. We'll also send a link out via newsletter once it's all uploaded and audio is all crystal clear. Number of really good questions here, so I'm going to try to pick just a few since we're coming up on the end of our time. There is one question about armor thyroid or natural desiccated thyroid in general.
Yeah.
Curious, I know here in cases of thyroid autoimmunity, we tend to avoid it. Just curious if you could speak to that a little bit, because that's something definitely on the cutting edge when it comes to thyroid management.
Yeah, due to time constraints, I really didn't go into detail in terms of different treatment options and, you know, NDT, armor thyroid, synthetic T3, T4. That's a whole nother slideshow. But the theoretical concern is that, so when we have NDT, which is just ground up porcine or pig thyroid glands, you can also get a hold of bovine thyroid glands out there, right? But you're getting everything. So you're getting thyroid globulin mixed into there. Remember I showed you the histology, the picture of what a thyroid gland looks like under the microscope? So when you ground up the thyroid, you're getting all that stuff. You're getting thyroid peroxidase and thyroid globulin. And so that could potentially add fuel to the fire if there's antibodies there, are giving them more substrate to generate more of an autoimmune response. Again, that's all theoretical. We've talked a lot about that as a group. No one's ever done a clinical trial on that. It probably never will be done because there's no money in it for anyone. But yes, so if you have thyroid antibodies, at some degree or some level, it makes sense to maybe not do NDT in that case, to use more of the, you know, synthetic T3, T4 combinations. Yeah. That's the rationale behind that.
Phenomenal. A lot of questions about Synthroid. I know you kind of spoke to this. The traditional approach is levothyroxine monotherapy, typically with progressive dose escalations, even with
Yeah.
minimal to no resolution in symptoms. Can you speak to, potential approaches for individuals who are resistant to, levo monotherapy? And then the thoughts about using Synthroid in cases when antibodies are high. I'm trying to jumble a couple questions together into one.
Yeah, no, I get what you're saying. So there's a lot, there is conflicting data when you look at, okay, does it really matter in terms of somebody's ability to go from T4 to T3? Now I can find you a study that says it doesn't matter. We should always just use LT4. The body will convert what it needs. That's kind of the prevailing theory by a lot of endocrinologists and experts out there. However, I gave you an idea of the complexity of all the different steps that are involved in converting T4 to T3. And you can imagine there can be plenty of room for variations in terms of people's ability to absorb micronutrients, people's ability to balance oxidative stress. There's no way that you can possibly encompass all of that and say no one will ever benefit from taking T3. Now, there are some more progressive, I'd say, endocrinologists, other doctors out there that will use T3, but still it's not really encouraged in a lot of the guidelines, right? I think that they're still pretty lukewarm about using T3 in only extenuating circumstances. I think T3, it can very potently suppress TSH, which makes people feel nervous, right? So if you give somebody above, I can't remember the exact cutoff in my head, north of 10 micrograms of T3, you'll see a profound TSH suppression, which again, people will say, oh my gosh, we're going to give you osteoporosis and AFib. Really not a lot of scientific basis or evidence behind that, but that's the thought. And so again, I think that if you have somebody that you're giving a T4 to monotherapy, and they're not responding, they're having continuing symptoms, it would make sense to consider either NDT or if there's antibodies, adding T3 to it. But you're going to get a lot of pushback out there in the conventional community for doing so.
I feel like this question, whoever wrote this probably knows you or is working with you because it's like very new question. But can you speak to any potential link between thyroid antibody elevation and candida infection specifically?
Oof. Yeah, that's an interesting question. I think that there's many different angles you could take it with that. Like, are we talking about candida, like small intestinal fungal overgrowth as a potential problem in causing, contributing to dysbiosis and affecting GI function, thereby affecting thyroid? Maybe that's what they're getting at. I don't know if I can make a direct connection between candida and thyroid, though. I'm not sure. Yeah.
Fair enough. There is some literature out there. It's scant, but speaking to, in female fertility, I think it's pretty well known that thyroid is incredibly important for,
Yeah.
successful conception and pregnancy.
Mhm.
But on the fertility side, I have seen some literature out there, really small sample sizes, speaking to azoospermia and sperm parent sperm morphology in cases of hypothyroidism. Can you speak to a potential mechanism there?
Yeah. I mentioned the sexual health implications that thyroid has with it as well. I'm not right off the top of my head familiar with the direct clinical evidence for that, but I know that when I was preparing this talk, I found multiple studies about sexual health, including those types of issues. And the pregnancy thing is huge too, right? If there's ever a time to have good thyroid function, it's during pregnancy, right? Because inadequate thyroid function is going to affect neural development, right? You can get something called cretinism, which is where the baby is born with multiple defects related to not enough thyroid hormone around, which is thankfully it's very rare in the United States, but all the more reason to be, vigilant about treating thyroid during pregnancy.
One of the questions here is asking, you spoke to the importance of iodine on a number of fronts. Any thoughts on serum iodine testing, if there's any clinical utility to that, or?
Yeah, I think if it's there, I'll kind of take it with a grain of salt. Hopefully there's also a urine level to help me. Now, if it's somebody that comes in, they're eating a bunch of, seafood and sushi and their serum iodine level is borderline, I don't know if I would really take that for anything. I would probably suggest that, if I really want to know iodine levels, I'll just insist on a 24-hour urine, and usually you can grab a couple other things when you do a 24-hour urine, because it's a pain in the butt to collect your urine in a jug for 24 hours, but it's a good opportunity to check a couple of additional electrolytes while you're doing it. It's not a very expensive test to do. It's just more of, like I said, the logistics of collecting your urine for a day. Yeah.
Maybe time it up with a road trip if you're not trying to make any stops.
Yeah.
Okay, phenomenal. I'm curious as well. This is just a question for me. I know a lot of clients that come in, especially men, their primary concern is just related to their testosterone and the levels there. And I feel like oftentimes guys that will come in with symptoms seemingly of low testosterone end up having pretty normal, somewhat optimal, maybe slightly suboptimal testosterone levels, but it seems like the thyroid is more of kind of the predominant needle mover when it comes to the symptoms that they're facing. Can you speak to like any link between thyroid hormone, testosterone levels, kind of the overlap in terms of like a symptomatic phenotype?
Yeah, I think one of the hierarchies that's taught, and I think is a good one, is that when you're looking at sort of the endocrine health of an individual, the base of your pyramid is going to be like your adrenal health, your cortisol levels, things like that, and then above that is thyroid, and then above that is your sex steroid. So without the base of that pyramid being functional, you're likely to have issues with testosterone, things like that. So rather than jumping right to TRT in some cases where there's overt dysfunction in either or both of those domains, it totally makes sense to correct those. And we've run into that many, many times before and see definite improvements. Yeah.
Do you have time for one more?
Yeah, shoot.
This might be more semantic in nature, but one of the questions is about, this individual has Hashimoto's. They've been told that there's kind of no cure for it. Is Hashimoto's or antibody elevation something that you can truly cure? Is it more so something that just has to be managed, like you said, with a multimodal approach, leveraging different strategies to mitigate risk and, resolve symptoms?
Yeah, I think you do both. I think you treat, and then you also try to fix any underlying causes. You do both simultaneously, because you don't want to be hanging around with suboptimal thyroid function for any longer than you need to. Like I said, I was trying to be very clear about, like, I do not have the cure for this, right? I just have some interventions that have been shown, have some evidence behind them. And it's always good to take advantage of synergy when you can, and not just do one thing. Particularly the majority of things that I talked about are so low risk. Aside from if you took a lot of DHEA, you might break out in acne. Okay, granted, but optimizing those nutrients and vitamins, and that's something that pretty much everyone would benefit from in some degree. So, yeah, and again, I think that there's just not a lot of great. How are you going to run a clinical trial when something depends on there's not one drug, right? It would be easy to run a trial if there was one drug that somebody came out with and said this will kill off or destroy all the thyroid antibodies. Oh, that doesn't exist. And so when you have something that requires so many different elements, it's going to be left aside of piece, take a jigsaw puzzle, right? Put all the pieces together and say, okay, we know from this clinical trial, this was helpful. It makes sense to combine it with this and kind of do those sorts of approaches. And you do see improvements, right? But can I claim 100% success rate of everyone coming in 6 months and having no thyroid antibody? No, of course not. I don't think there's anyone out there that would claim that.
I guess one more. Why do you think there is such a pretty substantial gap between the level, even on a testing side, the level of diagnostics that, someone's able to get at primary care without, haggling their doctor for years on years to go deeper down the rabbit hole versus
Yeah.
kind of the standards of care that we're aiming to practice over here? Because it does seem like there's just such a huge discrepancy between people coming in saying, oh, my my TSH has been 4.4 for 10 years and I have symptoms, but they tell me I'm normal and they're not going to look deeper, versus being able to come here and kind of get whatever you want tested and go to hospitals and what have you.
Several different answers there. First thing I think of is training. It's the way we're taught, right? When you're coming up through medical school, residency, and then if you decide to go into a fellowship in whatever field, the way you're taught is the way you tend to practice. After you're done training, typically most doctors are not going to be questioning what they were taught. There's a famous, I think it was an Sir William Osler quote about how within a year or even some sort of time frame like that, 50% of what we're teaching you is going to be proved wrong, right? And I still think that holds true today. So there's a gap in sort of the instruction that you get. I also think there's a fear about going outside of guidelines. Guidelines lag way behind what the literature shows. But once you start to sort of practice outside of those, there's fears of litigation, fears of being judged by your peers is a big role. And I also think that when you have lab tests that you aren't familiar with, and you don't know what intervention to take. So I think that if you were to ask a primary care, and I'm not trying to rag on primary care providers, I think there's lots of fantastic ones out there. It's a very difficult job. But if, let's say you go to them and say, hey, can you please measure my thyroid antibodies? I think what a lot of them are going to think about, you know, if I could be in their shoes, is that what the heck am I going to do with this? If you have positive antibodies, it's not going to change what I'm recommending to you because your TSH is normal. And I think that's the response you'll get. Yeah, hopefully that answers that question.
Yeah. Dr. Campbell, thank you so much for your time. Everyone in attendance, really appreciate it. If you're watching this on YouTube and you have questions, reach out to our team, www.merrickhealth.com. One of our health coaches will gladly sit down with you, kind of get to know you, build out kind of a custom diagnostic panel for you, and then get you connected with an expert provider like Dr. Campbell or maybe Dr. Campbell himself. So thank you all for attending. Have a great rest of your day.
Awesome. Thank you.